Hey guys, how are you doing? Welcome to our channel. MRCP made super easy. After a bit of hiatus and staying away, there was a bit of festival season going on, and I was not keeping well a bit. So yeah, we are back again, starting with a normal flow of things. And today's lecture we'll be talking about a good topic, a fairly easy topic called popliteal fossa. So we'll be covering most aspect, if not all aspects of popliteal fossa. So without further delay, let's get into today's topic. So when I say popliteal fossa, I want you to imagine a diamond shape. Why do I say that? Because a popliteal fossa is nothing but a diamond shaped space which is situated behind your knee joint. So a diamond shaped space behind your knee joint is what popliteal fossa is all about. So if somebody asks you next time what popliteal fossa is, you need to say, well, I have diamonds behind my knee. So that's what popliteal fossa is all about, right? So as always, let's look at the basic anatomy of popliteal fossa. So this is how it looks. Diagram for a popliteal fossa. Medially, it is bounded by the semitendinosus and semimembranosus. Above and below, you have the medial head of gastrocnemius. This is medially. Laterally, you have the lateral head of gastrocnemius and plantaris below, the biceps femoris above. It's very simple. Medially, we have a tendon and a membrane. Which tendon? Semitendinosus and semimembranosus. So we need to remember semi and semi. A tendon and a membrane. So semitendinosus and semimembranosus above. Since we are talking about medial aspects, so you have medial head of gastrocnemius. Laterally, you have lateral head of gastrocnemius and plantaris below. And above, you have the biceps femoris. Right? This is the basic anatomy. Don't forget, medially semitendinosus, semimembranosus. Medial head of gastrocnemius, I want you to say it along with me. Laterally, lateral head of gastrocnemius and plantaris below, and biceps femoris above. I'm sure most of you have said it, and don't forget, I want you to remember that, okay? And this fossa, this diamond shaped area is called the popliteal fossa, and these are its boundaries. Right, now how is the floor of this thing formed? It's pretty simple. The structures forming the floor. Since we are talking about the knee joint, the femur has to be involved. So the popliteal, we are talking about popliteal, right? So popliteal surface of femur. Then you have a capsule, the capsule of the knee joint. Then you have a ligament, the popliteal ligament. Just remember it as popliteal ligament. And then covering all this, you have a fascia, which is again fascia covering the popliteus muscle. So the floor is formed by everything that has to do with poplitea, popliteal, popliteal. So you have the popliteal surface of femur, you have a capsule of the knee joint, you have a ligament, popliteal ligament or oblique popliteal ligament, and you have a fascia covering the popliteus muscle. So remember, this is how the floor is formed, right? So these are the structures and this is the floor. So pretty simple, I'm sure it is. And the roof is formed by the, again, the fascia, that's it. So just remember that, alright? Next we'll talk about, but before we go into that, this is how the real popliteal fossa or the structure looks. It looks a bit gross, but this is how it is, right? This is a specimen. Right, now the contents. Now to remember the contents, now I know the image over here says S2P6, but don't go by that. I remember it as the 3-2-1 rule. What is that? 3 nerves, 2 veins and an artery, and then you have lymph nodes. So what are those three nerves? So pretty simple. Posterior division. Since we are talking about popliteal fossa, which is located posteriorly, so you have posterior division of obturator nerve. Next we have the posterior cutaneous nerve of thigh. Obturator nerves, posterior division. Posterior cutaneous nerve of thigh. Okay. Next we have the sciatic nerve. So 3 nerves. Posterior cutaneous nerve of the thigh, posterior division of obturator nerve, and the sciatic nerve branches. Then we have 2 veins. Since we are talking about popliteal fossa, so popliteal vein is one of them. The other one is saphenous. And artery, since we are talking about popliteal fossa, the artery has to be popliteal artery. Then we have the popliteal lymph nodes and a fat pad. It's pretty simple. So in order to remember the contents of the popliteal fossa, you need to apply the 3-2-1 rule. 3 nerves, 2 veins and an artery. Since we know it is popliteal, so the artery has to be popliteal artery. Since we know the vein also has to be something to do with the popliteal region, so it has to be a popliteal vein. The other one is a saphenous vein. Then we have nerve. Since we are talking about the posterior surface of the knee, so it has to be the posterior division of the obturator nerve, posterior cutaneous nerve of the thigh, and the remaining one is sciatic nerve. And then you have lymph nodes, again popliteal, so just apply popliteal and just write lymph nodes. So pretty simple. Apply the 3-2-1 rule to remember the contents of the popliteal fossa. I have already told you how the borders are formed, and I have also told you about the how the floor and the roof is formed, right? Now, why is this popliteal fossa important? Well, there is any clinical significance? Yes, of course there is. This is the reason why we are doing it. So we'll do it one at a time. The first one on the list is Baker's cyst, right? Now, what is a Baker's cyst? Now, the Baker's cyst, it is named because a scientist by the name Baker is the one who came up with it. That's why it got its name Baker's cyst. It is nothing but a fluid-filled growth or a cyst which is located behind the knee, and the type of fluid that is filled is called the synovial fluid, right? So a Baker's cyst is nothing but a fluid-filled cyst containing synovial fluid. So this is the synovial membrane lining of the knee joint, and it is filled with synovial fluid, and there is an adjoining connection into the cyst, resulting in formation of the cyst behind the knee joint, right? A cystic swelling behind the knee joint, which is called as the Baker's cyst. If you look at it in real time for a patient, this is how a Baker's cyst will look like. Okay, so a cystic swelling, just remember it as a cystic swelling, right? So as I told you, a fluid filled lump which is behind the knee, right? This is what a Baker's cyst look like. Cause is pretty simple. Let's say that if someone has restricted mobility for a long period of time, or they have injured it, or they have osteoarthritis, wear and tear in that particular region can result in formation of a Baker's cyst. The cause is pretty simple. It is also goes by the name known as popliteal cyst because it happens in the popliteal region. Now symptoms, quite simple. Uh, there will be pain, right? You will not be able to flex your knee. There will be stiffness in that area. It will look like has someone put a golf ball inside your knee, so a round shaped golf ball like swelling will be there. And because of this golf ball stuck into your posterior surface of your knee or your popliteal fossa, your joint flexibility will be limited, right? It's quite simple. How do I diagnose it? This is important. In order to diagnose a Baker's cyst, the gold standard is MRI. Ultrasound is also used, but MRI is considered as the gold standard. Well, the treatment for Baker's cyst, rice method. What is rice? R for rest, I for ice, C for compression, E for elevation. Give them anti-inflammatory medications, physiotherapies, EPAT therapy, also called as shockwave therapy. So shockwave therapy helps in reduction of the cyst. Steroid injections have been preferred. Draining of the synovial fluid is also an option, and in severe cases, surgery is the only option left, right? So treatment of Baker's cyst is rest, ice, compression, elevation, anti-inflammatories, steroid injections, EPAT or shockwave therapy, drain the synovial fluid, or the other thing is surgery. Well, let's head to the second one, popliteal pulsations. Well, the pulsations of the popliteal artery is felt in the popliteal fossa, and it is usually checked with the knee in flex position. Now the reason why we do that is because the hamstrings in the popliteal fossas are relaxed, so it is easier to feel the pulsations. And if there is absence of this popliteal pulse, it indicates that there is a femoral artery obstruction. Why? Because popliteal artery is a continuation of femoral artery. That's the reason why when there is absence of pulsations in the popliteal region, you need to suspect that the patient is having a femoral artery obstruction. Okay guys, keep it in your mind. Do not forget, as I keep telling you, keep revising and do not forget. Please go through this over and over again until you know that it is imprinted in the back of your mind. So keep reading it, keep revising every single day. Right, so the third is popliteal abscess. Not much to say about it. Since abscess, it is self-explanatory. You can have an abscess, and the treatment for that is you can go for an incision and drainage. The fourth one is tibial nerve damage, which is quite important. Now, the reason why a tibial nerve damage can happen is when you have posterior dislocation of the knee, right? Following a traumatic injury, you can have a fall or damage to the area can cause a posterior dislocation of the knee. or you can have laceration of the popliteal fossa, and this will cause damage or paralysis to the flexors of the leg along with intrinsic foot muscles. Now if that happens, what is going to happen? If you ask the patient to flex their toes, they will not be able to do. Plantar flexion will be difficult, they will not be able to do plantar flexion, and there will be loss of sensation in the area of the sole. Now for those of you, for your information, just this is what a posterior dislocation of knee X-ray looks like, and this is plantar flexion, this is dorsiflexion. So patient will not be able to do plantar flexion, he will not be able to flex his toes, and there will be loss of sensation in the sole area, and this is an X-ray showing you the posterior dislocation of the knee. Right, for extra edge, for those of you who want to know what knee dislocation is, the knee is formed, it has 4 ligaments, the posterior cruciate, anterior cruciate, medial and lateral collateral ligaments. Now if there is damage or rupture to at least 3 of the 4 ligaments, then we consider, or we say that the patient has a knee dislocation. So this is a bit of extra edge. It's not from an exam point of view, it's for your own knowledge. Well, next one, popliteal nerve blocks. Now, this is also something important. This is something we do very commonly in the emergency departments. For those of you who are working as emergency physicians know that. You use a vascular probe, right, to locate the area of the popliteal or the area you want to give a block. This is a tibial nerve over here. This is a popliteal vein, and this is a popliteal artery, right? So if we have to do a nerve block, so this is how we do it. The indications are when someone has a distal tibia or a fibula fracture. Now remember guys, this is quite tricky. Remember, you only give a block in case of a distal tibia fracture, distal, further away. Remember, you do not give, we will come back to that, why I am saying you this, why I am stressing on this distal is, I'll tell you in a little while. And analgesia for Achilles tendon. So when someone has an Achilles tendon rupture, you can use this method for giving analgesia, lower extremity burns and foot injuries. Right? Now why I was stressing on this distal area is because contraindication to nerve blocks is if somebody has a mid-shaft fracture of the tibia, you do not give them a nerve block. Why? It can lead to compartment syndrome. Right? Crush injuries. Why? Because the patient will be already having a vascular compromise. Trying to give a nerve block, you may cause bleeding, you may cause infection to this patient. So please do not go and give them a nerve block if somebody comes to you in a crush injury patient or someone has a mid-shaft fracture of tibia. Remember, distal tibia fracture and fibula fracture, you can give a nerve block, no problem. But in case of a solitary tibial fracture or a mid-shaft fracture, you cannot give them a nerve block because you're going to cause compartment syndrome. You're going to raise the pressure in that area and you're going to send them, it will become a medical emergency. So do not give them a nerve block in that area. So this is an important question, an important contraindication, and you got to remember that. Well, the last clinical important thing, popliteal aneurysm. Basically, aneurysm means, remember a balloon. So you have a balloon like a Baker's cyst was golf ball. Aneurysm is nothing but a balloon that is stuck over here. So it means ballooning. The weaker part of the artery results in a formation of this balloon, and that balloon can rupture and cause all sorts of problems to you in life. Right? Now, when can this happen? Clogging of arteries. Your arteries are becoming blocked as a result of wear and tear, atherosclerosis. Some patients who have uncontrolled blood pressures due to excessive pressures and blood running around across your artery can cause damage to the arterial vessel walls, leading to an aneurysm. Right? So weakening of the arterial walls due to excessive wear and tear. Patients who use their knee joints too much, smokers, right? Those who have stenotic heart diseases, male preponderance and advanced age. Right? These are the risk factors for patients who can go on to develop a popliteal aneurysm. Now an important note, any patient who has a popliteal aneurysm, remember that you need to screen them for an abdominal aortic aneurysm. Rest assured, any patient who has popliteal artery aneurysm, go and check them if they have an abdominal aortic aneurysm. If a patient is having abdominal aortic aneurysm, he is going to present you with severe kind of abdominal pain or chest pain that will be radiating to the back. Right? He might present to you in shock state as well, so it becomes a medical emergency for you. So popliteal artery aneurysm and abdominal aortic aneurysm go hand in hand. So screen them if they present to you with this condition. Symptoms pretty obvious. You're going to have an aneurysm, so you're going to have severe leg pain. Right? You're going to have difficulty in walking, so intermittent claudication will be there. If in case of a rupture or in case of a thrombus, there will be loss of blood circulation to that part. As a result of that, you can develop critical limb ischemia or sudden limb ischemia. And when you develop sudden limb ischemia or critical care ischemia, you're going to feel that area, there will be skin changes in that area, cyanosis can occur in that area, there will be loss of pulsations can happen in that area, right? So you're going to lose your limb. It becomes another medical emergencies, right? So how do I prevent this? Well, smoking, quit smoking, right? Lifestyle modifications, and keep your blood pressure under check and eat the right kind of food. Now, how do we treat it? Treatment depends on the size of the aneurysm, the symptoms, and the age of the patient. Right? If the patient, now medical management depends on, basically you can give them blood thinners, anticoagulants, keep a check on their blood pressure, do frequent checks, ultrasounds, and just to know, if there is any rupture happening or if there is increase in the size of the aneurysm. So you need to go for that. Now for the surgical management, there's just one indication. If the size of the aneurysm, irrespective of the patient is symptomatic or not, if it is 2 centimeter or 0.8 inches or larger, go for a surgical procedure. Right? If the patient is symptomatic, you think that he's going to develop a critical limb ischemia or anything, you can go for surgical management. Right? So that's the whole thing about popliteal fossa. So yeah, that's gonna do it guys for today, and I hope you got something out of today's video. And if you did, I request you to please do like, share my channel, and please do mention in the comments if my lectures are really helping you, because that's gonna give me a whole lot of happiness and confidence to keep doing this in the future as well, so that I can help as many students as possible and making their journey towards MRCP a much easier and less stressful one, right? So take care until next time. We'll join you again and we'll come up with more lectures, and we'll talk about more topics in detail. And if you have any doubt in regarding any topic, you can write to me and you can tell me, and I'll be more than happy to do a lecture on that as well, right? So take care. About that's the end for today, and we'll see you again. Bye bye.